the COVID-19 and the coronavirus will disappear from our region and from the world. And inshallah, next meetings will be doing these presentations, seeing each other in a direct way. Today, we will have a meeting regarding diabetes and nursing. And this meeting is actually prepared and done by the Saudi the Charitable Diabetes Association, جمعية السكري السعودية الأهلية. اسمحوا لي إني أتكلم بس بالعربي for few lines before introducing our first eminent speaker. جمعية السكري السعودية الأهلية أسست تحت شعار معا لمكافحة انتشار داء السكري برؤية التميز في الحد من انتشار داء السكري، ورسالتها الإسهام في التقليل من انتشار داء السكري وتخفيف معاناة من أصيبوا به، تحت أهداف كثيرة لدى الجمعية. من أهدافها تفعيل التثقيف السكري وتمثيل مرضى السكري لدى الدولة، والمساهمة في تطوير الخدمة الطبية وتقديم الدعم لمرضى السكري، سواء الدعم كان معنويا أو عينيا أو ماديا. طبعا لا يسعني في هذا المقام إلا أن أشكر أخواننا القائمين على الجمعية على الجهود المميزة والنيرة اللي يبذلونها دائما. هذه يعني اجتماع من عدة اجتماعات حضرناها للإخوان في جمعية السكر الأهلية تحت رئاسة أخونا عبد العزيز سعد الحميدي، الله يحفظه ويجزاه بالخير ويجعل ما يعمل في ميزان حسناته. Having said this, we will start the scientific meeting today. The scientific meeting is under the diabetes and nursing. And of course, everybody knows that diabetes is a very chronic disease, and it's unfortunately highly prevalent in our area. And diabetes is very it's a disease that is costing our nation lots in terms of money, and also in terms of the manpower, because diabetes actually is a disease of in our area is a disease of the working population. The diabetes again is a disease with chronic complications, like every one of you know, and we are privileged tonight to have three eminent speakers that they will talk about the prevalence of diabetes, and also about the classifications, diagnosis and complication of diabetes, and also the pharmacotherapy of diabetes. I am privileged to introduce our first speaker, Dr. Mohammed Sandid from Lebanon. He is an endocrinologist, neuroendocrinology, Saint Denis Le Monde. I hope my French, as Akhwan al-Lebanese, they know that our English, our French in this part of the world is not that great. He is the president of the Lebanese Diabetes Association, an IDF member since 1999, and also the MENA chair-elect in IDF, International Diabetes Federation. And also he is the founder and manager of the Lebanese National Diabetes Program from 2006 to 2013. Dr. Mohammed also holds so many places in Lebanon regarding and internationally regarding the diabetes and diabetes management, and he will speak to us tonight regarding the prevalence of diabetes in the MENA region, which is the Middle East, North African region. Dr. Mohammed, if you are ready, please go ahead.
Dr. Mohammed lecture is gonna be start at after 15 minutes, inshallah. But I'm gonna contact.
Well, if you could, if we could ask him to start earlier, so we'll buy some time. If at the end, if there is questions and answer, that would be great.
Okay.
دكتور محمد تسمعنا؟ معنا يا دكتور محمد.
الو سامعيني؟
السلام عليكم.
وعليكم السلام والإكرام.
دكتور محمد كيفك؟
والله الحمد لله، كيف أحوالكم؟
الله يحفظك ويعافيك. احنا طبعا you have to start like in 15 minutes, but if you are ready, if you could start earlier, so we'll have some times at the end for the question answer, if you don't mind.
Yes. بعمل share screen now ولا بعد شوي؟
Yes, please. Just go ahead.
Share screen. حطولي host disable participant screen sharing. اوكي. طلعت سكرين عندكم؟
لسه دكتور محمد صورتك. Riham, Dr. Muhammad is a host. He can share his slides.
Yeah, he can share.
لا قربي لهم احسن ما يشوفوك.
ممتاز. Now we can see
كويس.
your slides, Dr. Muhammad.
ممتاز. Fine.
Yes, please.
Can I start?
Yes, please. Go ahead.
Yeah. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. جمعية السكري السعودية، الأستاذ عبد الحميد العزيز الحميدي، اللجنة المنظمة، كل المشاركين. Thank you for inviting me today. In my talk, I will be summarizing diabetes prevalence in the MENA region. What I mean, the region that we included the Middle East, Gulf, North Africa, Iran, Pakistan, and Afghanistan. We have 9 IDF Diabetes Atlas editions started in the year of 2000. The last one published in 2019. So global prevalence, since more than a half century, diabetes has grown and expanded to become a pandemic affecting currently 463 million persons globally. Without sufficient action to address the pandemic, more than 578 million people will have diabetes by 2030, that number will jump to a terrible figure of 700 million by 2045. Unfortunately, most of those living with diabetes will suffer of its complication in one stage of their lives. These complications are the main cause of the morbidity, mortality, and very high cost of the disease. This is an introduction about the situation in 2019, according to the last IDF Diabetes Atlas. Now we have 1 in 11 adults from 20 years to 79 years. So we have now 463 million are suffering from diabetes. And 1 in 2 adults with diabetes are in diagnosis. So we have 232 million people in diagnosis. Over 3 in 4 people with diabetes live in low income and middle income countries. 10% of global health, global expenditure is spent on diabetes and its complications, around 760 billion USA dollar. So 1 in adults between 20 and 79 years have impaired glucose tolerance. So we have 374 million people, 1 in 5 people with diabetes above 65 years old. So we have 136 million people. In children and adolescents below 20 years, type 1, we have 1,110. 1 in 6 live births, 20 million, are affected by hyperglycemia in pregnancy. 84% of which is due to gestational diabetes. Now, the highlight, 38 million more adults with adults than in 2017, 22 million more adults are at risk of developing diabetes than in 2017, 13 million more adults above 65 years old with diabetes than in 17. Almost two-thirds, 63% of people with diabetes are of working age under 60 years. 20 million more adults with diabetes are in diagnosis than in 2017. 3,600 more children and adolescents have type 1 diabetes in 17. More than 33 million US dollar is spent on diabetes than in 17. Now, I will talk about the prevalence of diabetes in MENA region in North Africa. The International Diabetes Federation is a vibrant federation that includes 230 plus members across 170 countries. And divided into regional offices, where MENA region is one of them. The MENA region includes 21 countries. It includes all Arabic countries in addition to Iran, Pakistan, and Afghanistan. The diabetes prevalence is different between each country. These are the prevalence of diabetes according to the regions. And you can see our region in the orange color. Here, we will discuss global prevalence of diabetes. Worldwide, diabetes is increasing by 51%, being 463 million in 2019, and reaching 700 million as predicted in 2045. On the other hand, in our region, MENA, diabetes will dramatically increase by 96%, being 55 million in 2019, reaching 76 million in 2030, and 108 million in 2045, so doubling. You can see here the 21 MENA countries and the prevalence of each country. The lowest, the lowest prevalence is in Yemen with 5.3%, and the highest in Sudan was 22%, in Saudi Arabia 15.8%, and with Lebanon being in the middle with 11.2%. In this slide, we will see the prevalence of diabetes in MENA region. We can see that the regional prevalence in 2019 is 12.8% and expected to increase to 15.7% in 2045. In addition, the number of deaths due to diabetes is 419K in 2019, and the proportion of undiagnosed diabetes is 45%. In this slide, we see how the number of people with impaired glucose tolerance will increase from 35 million to 64 million, and we have the number of children and adolescents with type 1 diabetes being 149K, and of those newly diagnosed is 20K. In this graph, we can see that over the past 20 years, how the diabetes prevalence in the MENA region has increased from 7.7% in 2000 to 12.8% in 2019, having 55 million people with diabetes. In Lebanon, unfortunately, the number of prevalence diffract between different resources and are between 7.9% and 11.2%. And the reason is that most studies are not representative. That's why in Lebanon, we need to have more representative study to have more accurate number. Why is diabetes on this rise? The increasing prevalence of diabetes worldwide is driven by a complex interplay of socioeconomic, demographic, environmental, and genetic factors. The continued rise is largely due to an upsurge in type 2 diabetes and related risk factors, which include rising levels of obesity and healthy diets and widespread physical inactivity. However, levels of childhood onset type 1 diabetes are also on the rise. Growing urbanization and changing lifestyle habits, higher calorie intake, increasing consumption of processed foods, sedentarity lifestyle are contributory factors for the increasing of type 2 diabetes at a societal level. While global prevalence of diabetes in urban area is 10.8%, in rural area it is lower at 7%. However, this gap is closing with rural prevalence on this rise. Here, the estimate and projection of the global prevalence of diabetes between 20 and 79 year age group. In red, you can see the projection in the future, it's very high. Now, these are the number of diabetic patients rather than percentage. And you can see here that United States, India, and China are hosting most of the diabetic population in the world. But you can see in our MENA region as well is containing a very large number of diabetics after this three area. And in Egypt, Gulf state, and Sudan, the number of diabetes is remarkably increased. Here is a comparison between the urban area and the rural area with time. And you can see the percentage of diabetic population in the urban area are increasing with time between
Dr. Mohammed, we lost your voice. And also the picture. Riham?
أيوة يا دكتور.
There is a problem ولا ايش؟
هو الباوربوينت موجود لكن الدكتور صوته مش موجود، بس هو ستيل معانا في الزوم.
Sorry.
It's okay. Yeah, go ahead يا دكتور محمد. انقطع الصوت وانقطعت السلايد.
It's okay.
لا share your slide again.
هندخل تاني
لو سمحت.
يلا لحظة بس لو سمحت. شيرز. اوكي. يعني سوري لبنان شوي عنا مشاكل في الانترنت يعني ما تواخذونا.
ابدا يا دكتور، الله يحفظك ويحفظ لبنان كلها يا كريم.
الله يبارك فيكم. يلا لحظة بس. Okay, I think it's okay. Here, the comparison between the side of diabetics also, okay. You can see Pakistan and Egypt from our area, and you can see how the expenditure in diabetes is very low in these two countries. I think, okay, in our MENA region, the impaired glucose tolerance, as you can see, comes only second to that of the North America. Here, the prevalence of hyperglycemia and pregnancy in women, the MENA region are the lowest in the 7 regions of the world. 1 in 9 live births are affected by hyperglycemia and pregnancy. This is good for us. This is the mortality rate compared by age in sex, 20 and 90 in 79 years. You can see the middle age group is higher in men than in women group. With advancing age, as you can see, women are exceeding men. This is a proportion of this before age of 60 years. This is important slide. We are second after Africa, and before the age of 60 years is the highest of the world, and we are the second. This is a productive age, so just killing people in the productive age and places, in these places. Here, this is a health expenditure, the progress of total diabetes-related health for adults between 20 and 79 years will be increasing within 15 years. This slide shows the contrast between the rich and the poor countries in our area is very different regarding the discrepancy between the income of the countries like Qatar, العربية السعودية, المملكة, الإمارات, with low and middle income like Masr, Egypt, Sudan, Pakistan, Yemen, or sure now Lebanon. This is the total diabetes-related health expenditure. You can see here the inequality in expenditure between the rich and poor countries shows the benefits of healthcare between the different people with diabetes. Now, I will talk about COVID-19 and diabetes briefly. With the recent COVID-19 covered that diabetes deleteriously interacts with the infectious pandemic, and this negative interaction. On one hand, people living with diabetes are among the worst prognosis of those who contract the virus, especially when their glycemia is not well controlled. On the other hand, the infection leads to determine glycemic control and may be directly responsible for new onset diabetes. So, moreover, has been reported to be responsible for deterioration of the standard of diabetes care almost everywhere in the whole world. The MENA region, the characteristic of our MENA region are geographic area, and we can see a big with the population size, economic states, cultural hub, and much more. Some MENA countries have the biggest number of human disasters due to the civil wars, local conflicts, poverty, displacement, and in general, instability leading to high prevalence in diabetes. We have some difficulties due to the difficulties in the MENA region. Some countries are overcrowded and packed with refugee camp services, increasing the virus transmission. Due to the economic situation in countries, the supply of insulin, like Lebanon now, and medical equipment is limited. Many sanctions on few countries create difficulties in providing enough insulin to the population. The recent events in Lebanon, in addition to the near nuclear explosion that took place in Beirut, also slowed down the supply chain of insulin and oral antidiabetic drugs. Here are figures that will show and compare the MENA region in comparison with the world COVID-19. First of all, the case in the MENA decreased from May till October from 8% to 6.8%, compared with 13.7% worldwide. In addition, the population in US is 327 million compared to Egypt and Pakistan, 370 million combined. Noting that the mortality rate difference was 237,000 in USA and 13,000 in Egypt and Pakistan. The interaction between COVID-19 and diabetes, there are interaction is both directions. Diabetes can become pathophysiological. COVID-19 can lead to diabetes worsening and newly appearing. This is due to the increased diabetes prevalence in the region. We are urged to act now and apply the recommendation to control the situation, focusing on education, prevention, access, and care in public health. In conclusion, diabetes has been, and it is apparently will continue to be, a very serious and continuously progressive disease across the world, whole world. With the development of COVID-19 pandemic, that proper management and efficient medical care of diabetes is a key strategy in facing this infection pandemic. Huge work is still in front of us until we will be able to control the diabetes pandemic. On the occasion of the World Diabetes Day 2020 slogan, nurses make the difference, I want to congratulate MENA region for the wonderful role they play in the difficult circumstances. I always remember the saying I heard during the endorsement of the Diabetes United Nations resolution on 2007, when people work with integrity and commitment for a noble cause, sometimes the world listens. Shukran. Thank you for your lesson.
Thank you very much, Dr. Mohammed, for extremely excellent lecture and enlightening. I have one question for you regarding the prevalence of gestational diabetes. How would you explain the number of gestational diabetes in the MENA region is low, while the prevalence of diabetes is high? Is there any explanation or?
الو
Do you hear me, Dr. Mohammed?
الو
Dr. Mohammed?
الو
Dr. Mohammed, do you hear me? Yeah, it seems, Dr. Mohammed, can you hear me?
الو
ريهام معنا?
ايه نعم دكتور موجودة.
Yeah, it seems Dr. Mohammed, he cannot hear us. First of all, I just want to thank him very much for his contribution and for his excellent lecture. And if we, is Dr. Adil Al-Sayed ready to give his lecture?
إن شاء الله دكتور مصباح 5 minutes إن شاء الله and he will join us.
Dr. Misbah will go first, or Dr. Adil?
Yeah.
Riham?
نعم دكتور مع حضرتك.
Dr. The next presentation will be for Dr. Adil Al-Sayed or Dr. Misbah?
الدكتور مصباح إن شاء الله.
Okay, sure. So this is just for the audience. If there is any one of you has a question, they can post it in the question part, and we will at the end of the lectures, I will be happy to forward your question to our speakers. Dr. Misbah, of course, he will talk about the diabetes pharmacotherapy, and once he is with us, I will be honored to introduce him. While waiting for Dr. Misbah, and I hope he will join us shortly, as you might have seen in the presentation of Dr. Mohammed, that diabetes actually is hitting the middle-age population. People who are on the working age. So this is something that we really need to take care of, and also trying to prevent diabetes, and a lot of things that we could do to prevent diabetes, as we are one of the countries which is very highly prevalent in diabetes, is actually to promote good health practices, like good eating habits, exercise, and also the community also has to be a little bit vigilant to to diagnose diabetes. Some of our patients, unfortunately, they will be sort of in a denial state, even if they have the symptoms, which almost everybody knows that symptoms of diabetes like polyuria and polydipsia, but the patients usually they will ignore these symptoms because they don't want to be get the diagnosis of diabetes, and that's actually a very big mistake to be done, because as we almost everybody knows that if you diagnose diabetes early and you take care of it and keeping the control in a good manner, probably we could prevent the complication that affecting the middle-aged people and also the older people. But when these complications affect the middle-aged people and the working force of the community, that will be sort of a greater loss. So just increasing the awareness of diabetes and its symptoms and the way to diagnose it. Also, improving the healthy lifestyles, diet and exercise will be the way to go. Just trying to minimize the risk of developing diabetes. So, Dr. Musbah, still not with us, Riham?
بيدخل الحين يا دكتور.
Okay.
مساء الخير.
أهلا دكتور محمد.
آسف يعني لسوء الحظ، يعني الأيامات دول كتير الإنترنت عنا متقطع جدا.
ما في مشكلة، الله يسعدك. الله يحفظك. أنا while we are waiting for our next speaker, دكتور مصباح, I was having a question for you.
أيوة.
تسمعني دكتور محمد كويس؟
ايه سمعتك كنت عم تقول لي ليش الدايابيتس دايابيتس عندنا يعني انا I think انه البرسنتج للجستاسيونال دايابيتس in our MENA region between 10 and 15 يعني حسب البلد. I think السبب هو انه ما في investigation بالبريجننسي كافيه، lack of awareness، diagnosis ما عم ينعمل. لذلك هلا الاي دي اف مينا ريجن عم تشتغل على نيو جايد لاينز ان اور ريجن، وبدنا نشجع كثير الاويرنس خاصه عند الجينيكولوج، عند الجي بيز اللي بيشتغلوا بالجستاسيونال دايابيتس، لحتى يعملوا مور انفستيجيشن لنعمل اكثر اكتشاف لهذه الحالات.
اوكي، ثانك يو فيري ماتش دكتور محمد.
بس أنا can I ask you if the percentage of diabetes prevalence in Saudi Arabia is true؟ يعني unfortunately ال IDF ما عم ياخدوا الإحصاءات المضبوطة في منطقتنا. يعني برأيك أو خبرتكم مثلا المملكة العربية السعودية هذه الإحصاءات 15.7% صحيحة ولا we need more?
I think this number is underestimating the real prevalence in Saudi Arabia. We had a few studies. It depends on the age group that you are looking at. Of course, everybody knows that when we get older, the prevalence of diabetes will be higher. But there are few studies in Saudi Arabia. One of them were in the early 80s by Dr. Fatani from King Abdulaziz University at Jeddah. And the prevalence they quoted at that study was around 6%. But that was in the 80s, okay? And in 1995 or 94, 95, Dr. Naim and his group, and Dr. Khalid Rabi'an also, probably he's well known, they estimated the prevalence in their study to be around 12.3% at that time in 1994. And the study that we are quoting now is from the 2004, is Dr. Nuzha study, which the estimation was around 24% as diabetes and 14% as pre-diabetes. So basically, we have at least 40% of the population, they have some sort of impaired glucose tolerance, either diabetes or pre-diabetes. There are several studies, which is smaller ones from the Eastern Province. The estimation was around 27%. There is a study from our Ministry of Health. The estimation was around 13%. So we have conflicting numbers actually, but I think the number is more than 20%, to be honest with you.
Now, in Lebanon, we have very, very contradiction between study and other study. I mean, this number is very, very different.
Yeah, same here.
We need a representative study.
That's true. Yes, it's same here. But if you ask 3 endocrinologists in Saudi Arabia, probably you'll have 3 different numbers. But definitely the prevalence is higher than what the IDF is estimating at 15%. I think it will be more than 20% in Saudi Arabia. Okay, Riham, do we have our next speaker?
نعم دكتور، بتواصل مع دكتور. الدكتور مصباح موجود الحين يا دكتور عبد الرحمن.
مساء الخير يا دكتور مصباح. دكتور مصباح تسمعني؟ He's unmute. We have to unmute him. His mic is mute. دكتور مصباح تسمعني؟ دكتور مصباح؟ It seems دكتور مصباح
ايوه
السلام عليكم، مساك الله بالخير.
عليكم السلام ورحمه الله وبركاته.
كيف حالك؟ الله يحفظك.
الحمد لله. انا بس بحاول ادخل لانه انا كنت خارج المنزل، بس بيديني ان عايز الاي دي.
Okay, Riham, we have to deal with that.
Okay.
طبعا Riham is our technical person.
Okay, I am trying now. Give me 5 minutes.
Okay, let me just have a quick introduction to our colleague Dr. Musbah.
Yes.
Sayyid Kamil. He is a consultant in internal medicine and endocrinology at Minya University in Egypt. He is vice president of diabetes in the Asia Group, DASG, and also founder.
I am in now.
All right. Okay, he's a founder and secretary general of the Upper Egypt Diabetes Association. He's an IDF member of diabetes and in Ramadan International Alliance, DAR. All of us, we know the DAR and their great work that they have done for us and for the Muslims, diabetics. One of the principal participants of the guidelines committee. It will be our, he's member also of the Egyptian National Committee of Diabetes and Endocrinology. It gives me a great pleasure and honor to welcome Dr. Musbah to our meeting. And we are very privileged to hear from you, Dr. Musbah. Dr. Musbah will talk about the diabetes pharmacotherapy. Dr. Musbah, تسمعني؟
Yes, I am on mute now, and also. Okay.
تفضل يا دكتور مصباح.
I'll share my screen. Thank you very much, Dr. Abdurrahman. It is an honor and privilege to share with you in this prestigious conference and all activities of the Charity Association of Diabetes in Kingdom Saudi Arabia. I take this opportunity to congratulate and Sheikh Abdulaziz Al-Hamidi, one of our dear friends in the region, and I think this will be a very beneficial congress to all those who are concerning with the diabetes in the region. So I'll start, inshallah, my presentation by sharing my slides. And I enjoyed the lecture of the previous speaker, my dear Sandeep, as he enlightening the situation in the MENA region for diabetes. So he gave me the chance to skip some of the slides for the region. I hope my voice and my slides are now clear. And I'll start by my agenda. Okay, my agenda is to see the magnitude of the problem of diabetes, and this is enlightening very well by Dr. Sandeep. So I just skip this item, and the complexity of the disease that is give us many challenges while management strategies for diabetes in our region, and then we will speak on the anti-hyperglycemic agents, glucose-lowering drugs, either oral or injectable, especially in type 2, and what are the future consideration and my take-home message. So hyperglycemia and type 2 diabetes has many aspects and involving many of the pathophysiological pathways. So this will give an idea about how much we are opposing this, challenging this by not only one drug but multiple drugs. And in this era, rapidly increasing drug armamentarium every day, and now then since about 15 years, we have many injectable or oral, and this also hardly stop the progressive nature of the disease because of the complexity that we will talk sooner about it, and the different patient profile. So the complexity of the disease coming from the epidemic nature, and this is enlightened by Muhammad Sundid very well, and the multiple complications. Everybody knows that diabetes is a disease of complications, and the complicated pathophysiology and different patient profile and comorbid conditions. So we will go for the how to manage these different patient profile with complications and with multiple pathophysiology in a progressive epidemic disease like type 2 diabetes. Either we have the precision medicine or the personalized medicine. Personalized medicine can be defined in different ways. Shared decision-making approach that take patient preferences into account when developing the management plan, and identifying what is the set of phenotypic and genotypic markers that would define the ideal and non-ideal therapies for individual based on evidence on the real world, more than the clinical impression or genetic counseling or some sort of this. So this is a personalized medicine, or the individualization of medicine when we are facing type 2 diabetes. Right treatment for the right patient at the right time is always our goal when managing diabetes. On the same time, we have the term of precision medicine. Precision medicine is another science completely, and what is give us the response to that by genetic counseling or environment. So we prefer always to go to personalized medicine, but we need the evidence from the precision medicine. And with both of these, we have the tools to reach our goals of management in type 2. What are our goals? Our goals in management must be to relieve the symptoms, reduce the mortality, improve the quality of life. And I stress about the improve of the quality of life because it is the core of our management, and reduce the risk of complication, either macrovascular or microvascular. And we must start by defining what our glycemic targets. Always our general practitioners or primary care or even diabetologists with a discussion with their patient, and then to reach the targets, another lot of discussion about the ways to reach this. So glycemic targets, hemoglobin A1C if less than 7 without hypoglycemia, it will be very good. The preprandial from 80 to 130, and the postprandial less than 180, and going as far as we can to the normal blood glucose, obviating the hypoglycemia. And as we said, individualization is a key, because we have more stringent control for short disease duration, healthier, and no. When we are away from this, we have less stringent if there are comorbidities or extremes of age, elderly or very young, or there is hypoglycemia or short life expectancy, or the limited resources. So these targets must be reached within 3 to 6 months of diagnosis. We must obviate the clinical inertia, because the clinical inertia is very dramatically translated to complications, and the clinical inertia not only from the patient but also from the treating physician. So we must take care of this, and we must have our timeline discussed with the patient from the start, that way within 3 months we must go faster for the control. We must go faster also for the control less than 3 months if there is emergency, if there is comorbid, if we have per se accelerating lesion like proliferative diabetic retinopathy or deteriorating renal function or cardiovascular event. So this is must be in our mind. Also, we must not be glucocentric, because we must globally accommodate with the risk factors, especially the cardiovascular risk factors, smoking cessation, dyslipidemia, blood pressure control, and avoiding vascular events. The initial choice of therapy depends on glycemia and what is the stage the patient are in. Symptomatic hyperglycemia with metabolic decompensation, like as polyuria, polydipsia, weight loss, volume depletion. We have concern about injectable therapy here, especially insulin deficiency, and we cannot go more and more for oral agent. On the same time, if we have this emergency or this urgency is not settled, and we have our patient less symptomatic, and there is no metabolic decompensation, we must reassess our patient and go for hemoglobin A1C less than 7, and using as a lifestyle, using metformin, and starting when our hemoglobin A1C is more than 8.5, we must start in combination therapy, because we talked about multiple pathophysiology. So combination therapy here can overcome that challenge. How can we choose our agent after initial metformin? This needs individualization according to patient characteristic. So when we there is clinical cardiovascular disease, the priority of the anti-hyperglycemic agent will devote it to SGLT2 inhibitors and GLP-1, especially liraglutide and empagliflozin, because they have cardiovascular benefit. Also, when there are renal disease or heart failure, we will go to SGLT2 inhibitors first. And when we have a high degree of hyperglycemia, we must consider a powerful agent. The most powerful agent is insulin, but also we will see just soon what are the capacity of the glucose lowering drugs to lower hemoglobin A1C. And if there is risk of hypoglycemia, we must choose an agent that obviate hypoglycemia and be safe, like DPP4 inhibitors, like SGLT2 inhibitors, like GLP-1, or even if we are obliged to use insulin, we can use insulin analogs, the new generation. Also, for the cardiovascular disease and the multiple risk factors, these according to cardiovascular outcome trials. And when we have no access for treatment, like in our communities, we must look for the resources and have alternative therapies as we can to obviate the issue of non-adherence because of high cost or because of side effects. So this at diagnosis of type 2 diabetes, we can classify our patients according to hemoglobin A1C, and be cautious that hemoglobin A1C alone is not the barometer, because sometimes we have no standardization of hemoglobin A1C, so we must look for self-monitoring or the 7 points, or even if we can have continuous glucose monitoring available, this will give us an idea about the variable blood glucose all over the 24 hours, not only the hemoglobin A1C. But let us go arbitrary for hemoglobin and see that patient characteristic with the hemoglobin A1C consider us to give the agent of choice after metformin. And nobody can ignore the lifestyle that is always goes us through the management of type 2 diabetes. Here is the list of anti-hyperglycemic agents with renal function, because we need that we know that renal function is one of the most difficult issues in type 2 diabetes, and we see that all these I delineated in between are safe, and the others are not so. So we can choose from this according to renal function. So we must, before giving any prescription, to ask about the estimated glomerular filtration rate, or at least serum creatinine, and to know what stage in our renal impairment we are. These are now the injectable therapy in type 2 diabetes or type 1 insulin, and we have the always some misbeliefs around the insulin, but we must know that insulin either life-saving in type 1 or the next stage we can use in type 2 diabetes. And these are types of insulin, either the rapid-acting insulin or rapid-acting analogs, or the multiple basal insulins that are now rushing on our market. And we must remember that the NBH or insulin is one of the basal, but it have some drawbacks like hypoglycemia and hyperglycemia, and the analogs now like insulin detamir or glargine 100 or 300 or degludec insulin are more beneficial, because they have rapid onset, because they have long action during more than 24 hours, and less hypoglycemia because of this peaked. This is premixed insulin, and the premixed insulin have his it's a limited evidence-based narrow. It is not a physiological insulin, but the paradox is it is the more used insulin in our markets, and not on only our but all over the world, because of the ease of the use, just to give 2 doses. But it needs very consistent diet and lifestyle, otherwise we will have shooting up and down like this, and the hypoglycemia and the hyperglycemia between meals. So insulin analogs like Lespro, Aspart, and Glulizine, fast-acting or long-acting like detamir, degludec, and glargine are beneficial, especially in vulnerable patients or patients who like elderly or have recurrent hypoglycemic episodes, or those we are caring for transplanting organs. And this is the roadmap of the glucose-lowering medication approach. This we are talking about since a while, that when we are seeing any atherosclerotic cardiovascular disease, we will go first to GLP-1 and SGLT2 inhibitors. Otherwise, we will go further for the other agents, taking in consideration the safety and the less hypoglycemia and the less body weight adding or cost. If there is heart failure or chronic kidney disease, we prefer the SGLT inhibitor, DLP1, or go to the others. If we have hypoglycemia is in our concern, we can go for SGLT2 inhibitor, DPP4 inhibitor, GLP1, or TZDs. If we have the cost in our minds, we can go to sulfonylurea, especially new generations, or TZDs. And if we have generics from the SGLT2 or the other less hypoglycemic drugs, we can go for. And starting from monotherapy to combination therapy, either double or triple, and then injectable therapy. And when you're using injectable therapy, especially insulin, we starting with the basal oral regimen. We can give the basal insulin, and with the oral anti-hyperglycemic, like sulfonylureas, metformin, TZDs, DPP4 inhibitors, or SGLT2 inhibitors, accordingly to the character of the patient. If not controlled, we can add brandial insulin, either insulin regular or analog, in the meal or the meal with high glucose up, and we can change from basal 1 to basal plus 2 to basal bolus. If we have the opportunity to use GLP-1, it can lead to decreasing insulin, basal insulin, and now we have the mixture of basal insulin, glargine, where it's called the siliqua, and this can be used in controlling the advanced cases, or at last we can resort to the premixed insulin, especially insulin analog, if there is no opportunity to the basal bolus. Regarding the oral, we have all these oral medications. We can go for them according to their capacity to reduce hemoglobin A1c. We see that metformin came after the insulin, and then the new generations of secretagogues, then GLP-1 and TZDs and SGLT2 and DPP4 inhibitor. This table is very important when choosing our drug, so can estimate what is the hemoglobin A1c reduction the patient need, and then use a powerful agent. Please don't go to a weak agent just because of the you are prepared or you are no for reduction of hemoglobin A1c for a considerable amount. Metformin is one of the mainstays in controlling diabetes and type 2, and it is weight neutral, low cost, and have some gastrointestinal side effects. If these are not enormous, we can have a very good drug. And sometimes we have vitamin B12 malabsorption, so please consider for vitamin B12 supplementation. And it has cardioprotective, as shown by United Kingdom prospective diabetes study, and it is contraindicated if the below 30, and I think this is an old one. We can go further now, but we still needing the approval of the evidence, and starting it with cautious if the glomerular filtration rate is 45, and best not to start if not already started yet. And when there is any maneuver like iodinated contrast or imaging procedure, we must stop it for 48 hours and then return it again. If there is all the states of low cardiac outputs because of the lactic acidosis, and reevaluate the kidney function, estimated glomerular filtration rate after the procedure, and restart it again. Sulfonylurea, before I leave the metformin, the maximum dose is 2 grams per day, no maximum above this. and we can start slowly and go steadily to have this maximum dose. Sulfonylurea, I think nobody with the second generation, we have glybride, glyclazide, the glimepiride, and the glipizide. And the glimepiride and the glyclazide are very nice because of very supportive evidence of low hypoglycemia and renal protection, especially in advanced study with glyclazide. So they are giving us a good opportunity for sulfonylurea, and still they target the fasting and the postprandial hyperglycemia, and this is a very good option, and especially in the patient who is newly diagnosed, which are having the beta cell still healthy, and we can use it. And all the guidelines, either national or local, appreciate the use of sulfonylurea because of long duration of expertise and low cost and efficacy, but we must choose our patient well. TZDs is very important because it addresses the issue of insulin resistance, and only we have bioglitazone now after the story of rosiglitazone, and it causes no hypoglycemia and targets the fasting and the postprandial hyperglycemia, and on animal studies, it can give the clue for beta cell preservation. But I think the preservation came from reducing the glucotoxicity and the lipotoxicity, but it has the disadvantage of weight gain, edema, and bone fracture, and the issue of bladder cancer in recurring urinary tract infection in susceptible patient, not all, and the cardiovascular effect is bidirectional. If there is heart failure, it can be augmented, but it from the other side, it can reduce the dyslipidemic effect on the cardiac muscle. Ribaglenide and natiglynide, especially ribaglenide now is available. It is non-sulfonylurea, target postprandial hyperglycemia, and short acting, and they have less hypoglycemic effect. And the acarbose also targets the postprandial hyperglycemia. We have the stop NEDM study that evaluate the cardiovascular efficacy of acarbose, and it was evident that it is protective and beneficial for cardiovascular. And the main disadvantage are flatulence, diarrhea, but no hypoglycemia or weight gain, and it is not available now in most of our countries. DPP-4 inhibitors are a smart player in our field, especially the oral one, and they have no significant hypoglycemia or weight gain, and only we have the most common adverse effects about the upper respiratory tract infection, nasopharyngitis, or headache, and they are very efficient in as adjuvant drugs for controlling type 2 diabetes. And the issue of pancreatitis is no more raised except in susceptible patient. And we have also sodium glucose transporter 2, which is the newcomer or the new player in our type 2 diabetes, and they have very efficiently reduced the hyperglycemia in non-traditional way. It is not a secretagogue, it was acting according to the insulin secretion, but it only inhibit the reabsorption of glucose in the proximal convoluted tubules, so it leads to regain of the normal physiology of the kidney for glucose absorption in type 2 diabetes, and the reduction of weight and the blood pressure is a very advantageous clues of these drugs. And the only disadvantage is increased genital mycotic infection, and it cannot be used with reduced estimated glomerular filtration rate, and we must check for the urinary tract, for the electrolyte balance, and when the patient is starved, there is concern of ketoacidosis, and so we must be cautious. We must be cautious also in a very warm weather, like in our Venezuela, or our Gulf countries, because of the volume depletion and the thrombotic events. Also, the bladder cancer incidence must be concerned, especially in susceptible patients, and the cardiovascular benefits with the empagliflozin are now established. There are some drugs that are not commonly used, but we will just enumerate them. Bromocriptine, as it is increased the CNS dopaminergic activity, which is altered in type 2 diabetes and leading to postprandial glucose reduction. Cholecalciferol also lowers the cholesterol and improves glucose control, but has side effect of constipation and nausea and dyspepsia. And the mostly GLP-1 agonist and thyroid carcinoma issue now is observed in animals, but now there is black box for exenatide warning for thyroid carcinoma, contraindicated in persons of family history of medullary thyroid cancer. And bramlinitide, also one of the injectables, synthetic amylin, and it was tried for a while in the United States because of it promotes satiety and slow gastric emptying and inhibit postprandial glucagon. But now the noise is going on, and I think it needs some trials to therapies must be individualized. We have multiple tools we can choose according to the characteristic of the patient and the priority of the patient. And diet and exercise, lifestyle and education are the foundation. And unless contraindicate, metformin is the first line of the drug treatment. And with metformin, we can start combination therapy early, either with oral or injectable, and oral or merely injectable like insulin and GLP-1 injectable. And we try to go for the normal blood glucose without hypoglycemia and minimize the side effects. And many patients will require insulin therapy. And thank you very much. I am sorry if there is some prolonged speech in this subject.
Thank you very much, Dr. Masbah. I really appreciate your effort in summarizing a very large topic in like 25 minutes. Each one of these medication actually needs a lecture on its own.
Yes.
You know, DB4 inhibitors or GLP-1 agonists.
Yes.
You know, different type of insulins. I really appreciate your effort and for being with us tonight. Our other speaker, unfortunately, he cannot be with us, Dr. Adil Sayed, due to due to some problems that he cannot be with us tonight. So I would and unfortunately myself also, I didn't prepare slides, but the diabetes usually is defined as hyperglycemia or high blood sugar resulting from insulin deficiency or insulin resistant. That usually associated with complication, chronic complication, like retinopathy or nephropathy or vasculopathy and neuropathy. The way that we diagnose diabetes is we have now two ways to diagnose diabetes. First is having the fasting blood sugar, which is the normal should be less than 100 milligram per deciliter. and the diabetic usually more than or equal to 126. So if the blood sugar is more than 126 in a fasting after 8 hours fasting, that will raise the concern that we are dealing with diabetes. People who are in the fasting state from 100 to 125, we call them impaired fasting
Pre-diabetic
glucose.
stage, yes.
Yeah,
Impaired.
impaired fasting
Yes.
glucose.
Yes.
And these people are also needs to be actually followed and need to be advised regarding diet
Yes.
and exercise.
Yes.
Regarding
Yes.
the postprandial, the normal should be less than 140. From 140 to 199, this is impaired glucose tolerance.
Yes.
And if more than 200, this is diabetes. And we are using also the hemoglobin A1C to diagnose type 2 diabetes. So if the hemoglobin A1C is normal is less than 5.7, from 5.7 to 6.4, this is pre-diabetes, and more than 6.5 and more, we consider them to be diabetic. The classification of diabetes is
But
with a type of,
excuse me, I want only to interfere here for a clarification point to our colleagues. Okay, this is the way of diagnosis. It needs some remarks. First of all, if we have abnormal fasting or abnormal postprandial, we must again retest this and second day to evaluate that this is diabetes or just an occasional blood sugar, hyperglycemic blood sugar, not constant. And the next point is that hemoglobin A1C is a good tool, but it must be standardized according to the clinical federation of the chemistry. And if you have this diagnosis of diabetes, you must also go for fasting and postprandial to make sure, not only for the diagnosis, but also for the management, because sometimes we have hemoglobin A1C within the range, but there are variability between the meals, and we have ups and downs of blood glucose that need to be addressed. We cannot address this except with the self-monitoring or for monitoring blood glucose for the 7 points or continuous glucose monitoring. This is what I want to add to your valuable speech.
Excellent, Dr. Musbah. And I'm just trying to summarize Dr. Syed lecture without
yes,
slides.
You can ask if there is anything we can clarify.
No, that's okay. So the types of diabetes, actually we have 4 types. Type 1 diabetes is an autoimmune disease that actually happens with in young age group, that these people, they need insulin actually to survive. So type 1 diabetes, and type 2 diabetes mainly is insulin resistant, but maybe at the end of with the chronicity of the disease, they might have also insulin deficiency.
Yes.
But this is the most common type of diabetes, which is type 2 diabetes. More than 90% of the diabetics that we see. And also the gestational diabetes, which is diabetes during pregnancy. And the 4th type of diabetes, if there is a cause for diabetes, like if you have a patient on steroid therapy, or with other endocrine diseases like acromegaly or Cushing disease, or a patient had, let's say, pancreatectomy surgery for the pancreas. So those are the diabetes with a cause. The complication of diabetes usually is very common, unfortunately, in our community. The diabetes is the most common cause of blindness in Saudi Arabia. We used to have the trachoma, an infection of the eyes, but nowadays, actually, unfortunately, retinal disease is the most common cause of blindness in Saudi Arabia as a complication of diabetes. And nephropathy also and kidney failure is a very common complication of diabetes. And neuropathy and vasculopathy, like myocardial infarction, are very common with diabetic patients who are not controlled. And also we have the neuropathy and diabetic foot. The diabetes foot is the most common cause of lower limb amputation, non-traumatic lower limb amputation. So we have actually reasons to ask our patients and to try to control their blood sugar. And the main reason for controlling their blood sugar is actually to trying to reduce the complication. The main reason for treatment is actually to reduce the chronic complication of diabetes. At the end of this day, I just want to ask to thank Dr. Musbah for his contribution. I want to also thank Dr. Sandeep for his lecture, and I would like to thank our audience for their time. And tomorrow, inshallah, we'll have our second lectures. We'll start at 7 p.m. Riyadh time, and also we'll have a very important lectures tomorrow. Dr. Muhammad Al-Muhdil will talk about the stem cell treatment of diabetes, new form of diabetes management. And also Dr. Elizabeth will talk about the time and range, which is a new mode of making sure that your patient is in range when you treat their diabetes. And we'll have also lectures regarding the role of diet by Dr. Hanan, and also we'll have two other lectures regarding the nursing educator roles and the nursing role in managing diabetes. So with that, I want to thank all of you for being with us tonight, and I want to thank our speakers, and also Riham for her contribution and being patient with us. And I will see you tomorrow, inshallah, tomorrow at 7 for great lectures. Thank you very much.
Thank you, Rashid. Appreciate you, and congratulations for you are managing the session very well, Dr. Abdurrahman, and my also talk. I hope it was beneficial, and my regards to Dr. Sheikh Abdulaziz and all the members of the Charity Saudi Association. Thank you very much.
Shukran. Assalamu alaikum. Thank you very much. Bye-bye.